Thank you, Professor. It's an honor to co-chair with you this session. Thank you to the organizing committee of the Hellenic Urological Association for inviting me for this talk. I will talk about mostly about the management of what we do after we have a biochemical recurrence after radical management for localized prostate cancer. After that, yeah. Okay, I have the pointer, and this is the. All right. So, as we know, a part of patients after radical surgery will experience. It's not working. Will experience biochemical recurrence, and from all these patients that will recur, a third of them will go on to metastatic disease, and that will take a long time. And a part of these patients only will go on dying after amount of time, which is around 5 years. So, as we know, the whole natural history of prostate cancer is quite long. I have a problem with this thing. Okay, so let's talk about now the definition of biochemical recurrence. After radical prostatectomy, we all know that we have 0.2, 2 increases above the 0.2 level, and after radiation therapy, we have the increase of 2 nanograms above the nadir value. Is this working with the, okay, this is better. So what we need to know after a biochemical recurrence is we would like to know which of these patients will recur. And do we have any tools beforehand? Before therapy, we all know that we can separate patients into low, intermediate, and high risk, and according to their chance of having a biochemical recurrence of 25 or 50%. And this is based on the PSA values, clinical staging, and Gleason score. After having the radical prostatectomy, we have one more advantage. We have the pathology report back. So we know that using our Gleason score, our extracapsular extension, seminal vesicle invasion, lymph node metastasis, or positive surgical margins, we know that these patients have a higher risk of recurring afterwards. Now, the first question that rises up after biochemical recurrence is it local or is it distant? The first thing we would like to do is if we could have imaging. Well, CAT scans and bone scans are usually useless at this setting because PSA values are very low and they're not very useful. After radical prostatectomy, PET PSMA could be useful, but we need to have increased sensitivity and specificity if we have PSA values above 1. Below this value, they're not very sensitive. For after biochemical recurrence after radiotherapy, well, multiparametric MRI and PET CTs have some role, especially if we want to do some treatment for these patients. But in general, after radical prostatectomy, imaging is not very useful because we need to do something before PSA rises above 1, as we will see later on. Now, we can use some clinical parameters to guess if we have a distant metastasis or local recurrence. And we usually use the Gleason score, the time of recurrence, and the PSA doubling time. Essentially, we can predict with an 80% chance that we would have a distant metastasis if we have a fast PSA recurrence below 1 year. We have a quick doubling time, around 4 to 6 months, or we have high Gleason scores in our prostatic specimen, or we have extended disease in the specimen as well. While we will have a local recurrence, and that with a chance of 80%, if the recurrence is late after surgery, if we have a slow doubling time above 10 months, and we have Gleason scores that are equal or low 7, or PT3A and no lymph nodes present. PSA doubling time is very important in order to figure out if we have a distant metastasis or local recurrence. Usually, quick doubling times are a bad sign and define metastatic disease, while slow doubling times are more likely to be present with local recurrence. PSA doubling time is something that is not very easily measurable if we want to do it on our own. However, there are some sites that are available, and we can put our data in and have the doubling time very easy, so urologists must use it more and more. Now, after radical prostatectomy, bad signs like extracapular disease, positive surgical margins, seminal vesicle invasions, Gleason score of 8 or more, will mean that sometimes the PSA will recur, or sometimes the PSA may never become 0. What will we do? Well, usually we will proceed to radiation therapy. The timing of radiation therapy is something that is for debate. Usually we can give radiation therapy immediately after the radical prostatectomy, around 2 to 4 or 6 months after the procedure, or the other time is we can wait until we have a deep biochemical recurrence and do radiation therapy afterwards. This is called salvage. So what we need to keep in mind that there might be a balance. The debate here is that if we give salvage in a late time, are we missing a therapeutic opportunity? If we give our adjuvant early after surgery, are we treating patients that might never recur, offering increased toxicity and over-treatment for our patients? Well, comparing adjuvant radiation therapy, there are 3 large trials, all of which are randomized, controlled, and provide a high level of evidence. They're the American, the European, and the German trial. All of them have a large amount of patients, have patients with similar characteristics, the long follow-up, adequate follow-up for evaluation of the results. All 3 studies provided that there is, concerning biochemical-free survival, all 3 studies showed statistically significant better results when we provide radiation therapy after radical prostatectomy and bad prognostic signs compared to surveillance. Overall survival was improved 10 years in the American study only. In the European and the German, this same survival advantage was not demonstrated. So adjuvant for sure helps us with our biochemical-free survival, but not with overall survival for sure. What are the drawbacks of giving adjuvant therapy early after a radical prostatectomy? Well, not all patients will recur. See here, if we have a positive margin and a Gleason 7, the biochemical recurrence chance is 65%. However, if we have a positive margin and a Gleason score of 6, the biochemical recurrence will only be 25%. That means that having a positive margin does not necessarily mean that we will have a biochemical recurrence, and therefore adjuvant therapy is over-treating part of these patients. What if we have extraprostatic extension and negative surgical margins? What would we do in this situation? And this is a very common finding. All of us have encountered such findings. Well, a sub-analysis in the American trial was never performed, so we don't have any result from there. However, the German and the American, the European study showed a reduction of biochemical-free survival. However, overall survival improvement was not evident. Expert opinion, I could not leave Pat Walsh out of the situation. Well, in his editorial in a European journal several years ago, well, he stated that he does radiation therapy after having positive margins and a high Gleason score 4 to 6 months after doing radical prostatectomy. However, he will not do radiation therapy if he has a negative surgical margin, despite the fact that he might have extraprostatic extension. He will avoid doing radical radiation if he has a bladder neck contraction, and for sure if he has still incontinence, because all this will pigorate after radiation therapy. And he would not select radiation if he has a patient that's 70-year-old, and unless he is very healthy and he has high-grade disease on his positive margins. Regarding invasion of seminal vesicles, well, there is no benefit in the German study. However, the RTC showed some improvement in biochemical-free survival. So the marginal benefit of doing radiation therapy after a positive semicolon vesicle is debatable. One can choose depending on what he believes. We have to keep in mind that adjuvant radiation after radical prostatectomy increases toxicity. Essentially, complications regarding strictures, incontinence, rectal complications are doubled after radiation at this early point. For the GU, toxicity is around 14%. GI toxicity is around 9%. Unfortunately, high-grade toxicity is very lower, and mostly for the bladder, it's around 2.3%. Now, we know that we prefer to give the highest dose at the lowest possible PSA value. This is true. We have better results, but at the cost of having more side effects. Especially, this is true for the bladder, which is mostly affected. Now, one of the drawbacks of adjuvant is that in these studies, a lot of patients never decreased their PSA to 0. So essentially, they had persistence of PSA, and in effect, truly, the radiation therapy that was given at that point was essentially early salvage. So this confuses our results, and further evaluation was performed. Essentially, they wanted to see how patients performed at different PSA values when salvage radiation was given. We saw that the lower the PSA, the better the biochemical-free survival was. If we provided radiation at PSA values below 0.5, we had a 6-year PFS of 48%, while if we had PSAs above 1.5, this PFS dropped to 18%. So it is recommended that we offer salvage radiation therapy at PSA below 0.5. If we do this, it is very probable, and there was a big study comparing early salvage versus adjuvant, and we saw that there was no difference. The 2-year and 5-year survival was the same, and regardless of we had positive margins, if we had different stages, early salvage, as long as it is given early, before 0.5, has similar results to adjuvant therapy. That told us essentially that we could avoid giving radiation therapy to all our patients, avoiding complications. And that is illustrated essentially in a big study that showed that the use of radiotherapy is declining due to all these complications that are associated with adjuvant therapy. Now, do we give salvage radiation with the use of hormone therapy? Well, there are not a lot of studies. However, the use of LHRH for 6 months showed some statistically significant, mainly for the biochemical-free survival, while bicalutamide for 24 months showed similar BFS improvements, but also overall survival when used with salvage external beam radiation therapy. Can we use androgen deprivation after biochemical recurrence as a monotherapy? Well, studies show conflicting results, and we could use it only in high risk for progression patients, since hormone therapy has its side effects as well. Could we do nothing, since the progression of prostate cancer takes a long time? Well, probably in low-risk patients for progression, we could wait until metastatic disease develops, and this is an option for several of our patients. What do we do after failure of external beam radiation therapy? Well, we have to keep in mind, because we are urologists and many of of us are not very familiar with radiation oncology, that after radiation, we could have a PSA bounce at 12 to 18 months, which is not a biochemical recurrence. We should wait 18 to 24 months after the PSA reaches its nadir. And we need to do something after failure of external beam radiation therapy. We need histological confirmation, which needs expertise because the pathologist needs to be experienced. And all this has a meaning and makes sense only if our candidates our patients are candidates for salvage management, if we are going to do something in the salvage setting. Well, what can we do as a salvage setting? Well, we can do a radical prostatectomy, we can do a cryo, we could do brachytherapy, we could do HIFO. Which is the best? Well, there are no recommendations at this point. Anyone can use what he prefers, what he knows what to do, what he has experience with. What is uniformly similar is whichever salvage treatment we do after failure of radiation therapy, we will have bad results. The biochemical free survival are not very good, at least they're mediocre. And at the cost of increased complications, complications are more, especially for salvage radical prostatectomy. We all know that it's a very difficult procedure. Incontinence rates, stricture rates, fistulas can occur, and erectile dysfunction for sure is very, very bad. Therefore, could we do nothing? Could we wait after failure of radiation therapy? Well, it is an option. It seems that patients with prolonged doubling time can be surveilled, and we cannot do, and we can do just wait for these patients to develop a metastasis. And finally, our conclusions is that if we have we need to know, patients want to know if they have a risk to occur and what we will do afterwards. Well, adjuvant radiation therapy is an option, has a good biochemical free survival at the cost of increased morbidity. Salvage external beam radiation is, for me at least, a preferred option, although it should be offered early during the during the recurrence period. We should not wait until the PSA passes the 0.5 level. And salvage therapy after radiation therapy is a difficult issue. There are many complications, and our results are relatively mediocre at the best. Thank you very much.